Hi, it's Ahmed Salam here back again. This is an interesting case I'm doing with one of the senior residents. It's so dense cataract. So the plan is to use a Miloop to crack this lens. So we start here with a trypan blue and rexes. We start with a cystotome. Usually we start with a forceps, but in this case we start with the cystotome, then using the forceps here to complete the rexes. Remember, important to make sure that the AC is very deep. And if this lens is inflated, you need to decompress the lens, which we did not feel that this is the case here. You stop at the wound and then redirect here and then keep curling and then you finish off out to in. I will discuss the rexes in another session. And then hydrodissection, and hydrodissection should end with rotation. So that's done. Now this is the Miloop part coming. And the important thing is to introduce it and then as you get it under the rexus to open it fully, rotate it vertically and try to see it as you can see here, and now close fully while you push on the lens back so as not to get a zonular dialysis. And now you rotate the lens and you do the same thing again. In a hard cataract like this, you need to push the lens back. In a soft cataract, you can do it single-handed. The important thing is to make sure it's vertical, close fully, and then come out. And here we have 4 cracks. Now I switch with the resident, and the resident is doing that part, removing the 4 quadrants after they've been split with the Miloop. And you can see here there's a good split and he can snatch them in and removing the lens here. I slowed this session to 2 times speed. The first part was 8 times speed, and I just want you to see what happens here. There's a period where we will go through that quadrant and you can see here there's a kiss in that quadrant. Whether this is full thickness or not, we did not feel so. I think important is you don't want to cavitate through the quadrant and you keep always pushing it in front of you to get it from the edge to avoid that situation. So now I will manage this by putting some viscoelastic and then going to remove this last quadrant again. Still here at 2 times speed, and you'll see that getting inside the eye with the phaco tip and the chopper to remove that quadrant. And this is the trick, is to keep pushing everything in front of you so that the quadrant, so you don't cavitate through the quadrant, which I think here is done very nicely. And then the last piece working single-handed is good because then you have the AC deep. One thing happens here as we're trying to remove that part of lens matter stuck in the wound is that we notice that there's a posterior capsular rupture present and it extends. So the question what to do here, this is what we usually do. We put triamcinolone to stay in the vitreous, and you can see here there's actually a vitreous knuckle protruding through the posterior capsular tear. So vitrectomy is needed. We chose to do a 1-point parasplantar anti-vitrectomy rather than limbal. Very important here is to make sure that the eye is inflated. That's so important before you make the entry, because otherwise you can make the entry more posterior than expected, and you need to be careful because the eye can have hypotony at this stage. Once we're in, we'll do an anti-vitrectomy and remove the vitreous around the posterior capsular tear, and then we may need to do additional vitrectomy in the antechamber as I've done here to make sure there's no vitreous. Then you put viscoelastic and then come out. Here's what we've done here. The capsular tear was reaching till the periphery, but still was localized enough so I can put a lens in the bag, but without converting this to a posterior capsulorhexis. And here's a learning point. I did this but using still a wound assisted, and I would not advise that when you have this situation. It just makes you in a position where you're not able to direct the lens well, and this is exactly what happened. The lens went actually into the antivitreous, as you can see here. Question again, what to do? Things are getting complicated on the IOL as in the anti-vitreous. So here I'm using 2 vitrectomy forceps, one to secure the lens from the haptic, and the other is to put the lens into a horizontal plane, now dialing the lens back into the sulcus. And after that I was just able to open, as you'll see here with the viscoelastic, the bag and put the haptics back in the bag. So here I'm just checking, and then I'll start putting the haptics back in the bag again, in the sulcus, then in the bag. There's enough posterior capsular clearance to put it in the bag in just the direction here, and I got the inferior haptic in, and now I'm just gonna dial the superior haptic in the back. Now back tidying up with some additional vitrectomy from the back, removing some of the viscoelastic and making sure there's no vitreous here, and then after that removing the viscoelastic from the antechamber. Here I'm checking that there's no vitreous in the antechamber by putting diluted kinologue, and I can see that the pupil is rounded, there is no lens matter, and the IOL is stable in the bag. I'm utilizing my assistant to put pilocarpine myostats through the main wound here to close the pupil. Again, just checking for vitreous. Now I keep the AC deep as I come out of the eye and put more, hydrate the wound and try to maintain the AC deep, as you can see here. So the trick is to try to keep the AC deep so no more vitreous prolapses. This is the end of the case, and here we put a stitch to close the wound as the case was complicated to remove the choker, and then usually we see the patient the next day. These are the learning points from this case. I think Miloop is a useful tool. Be very careful with last quadrant and do not use a wound assisted technique if you have a posterior capsular tear or if you have a posterior capsular rhexis. I would enlarge the wound and just be able to direct the lens better to place it in the bag. Thank you so much for watching.